Hello, my name is Murdoch Millwood. I am a BVM student of the class of 2026 at Oregon State University. My topic today is treatment of status epilepticus and cluster seizures, and my advisor is Dr. Courtney Korff, a neurologist at Northwest Veterinary Specialists in Portland, Oregon. All right, so a brief rundown of what we're going to cover. We're going to review what seizures are and their pathophysiology. We're going to talk about the phases and clinical signs. We're going to define status epilepticus and cluster seizures, as well as review the ACVIM guidelines and treatment recommendations. So, what exactly is a seizure? A seizure is defined as a non-specific paroxysmal event that can have an intracranial or extracranial etiology with multiple presentations. While this does define exactly what a seizure is, I find this definition incredibly vague and not very satisfying, so hopefully over the next few slides we can gain a better understanding of what exactly is causing seizures. Alrighty, so the best way to understand any disease is to review its pathophysiology. First off, I want to say that this is a very brief overview of seizure pathophysiology. As you can imagine, it's very complex, and if you want a more detailed overview, I have references at the end. So, starting off, seizures occur from transient and uncontrolled synchronous electrical activity of neurons, causing increased excitability and reduced inhibition. The mechanism of the excitability is the action potential and some form of stimulus leading to a hyperexcitable state. These action potentials lead to membrane depolarization down the axon and induction of neurotransmitter release and then subsequent binding at ligand specific receptors. The major excitatory neurotransmitter in the brain is glutamate. It will bind postsynaptic receptors such as AMPA, NMDA, and kainate receptors. When bound, it leads to influxes of sodium and outfluxes of potassium and membrane depolarization and excitation. The major inhibitory neurotransmitter is GABA, which interacts with the receptors GABA A and GABA B. GABA A receptors are found postsynaptically and, when activated, allow for influxes of chloride ions, causing hyperpolarization and inhibition of the action potential. GABA B receptors are found presynaptically, and they're more responsible for secondary messenger systems that lead to potassium channels opening, causing hyperpolarization and inhibition. Another important concept that we won't dig too deeply into regarding seizure pathophysiology is how seizures can spread and become generalized. Seizure activity almost always starts at a focal location within the cortex, and these are known as epileptogenic zones. With repeated or prolonged focal hyperexcitability, this can begin to overcome the surrounding GABAergic inhibition and spread from the epileptogenic zones into regions known as propagation zones. These can then spread between hemispheres and become generalized. However, this is a bit of an oversimplification, and there's a multitude of pathways that leads to widespread seizures. Alrighty, now that we have a better understanding of seizure pathophysiology, let's break down the different phases and clinical signs of seizures. Starting on the left, we have the prodromal phase, which is the period of time before the onset of a seizure event, which can occur days before. The most common clinical signs seen in this phase are changes in behavior, such as anxiousness and hiding. Next, we have the aura phase, also known as the preictal phase, which is the phase that occurs immediately before a seizure. Signs include changes in behavior, altered states of consciousness, and autonomic dysregulation. Both the prodromal and preictal phases commonly go unnoticed, and in some cases, animals don't really experience them at all. Next, we have the ictal phase. Ictus is the actual seizure event itself, and probably what we're all most familiar with. Unfortunately, these do have a highly variable appearance and duration. Examples include focal or partial seizures, which only involve part of the forebrain and can look like rhythmic contractions of a single muscle group, such as tail twitching or eyelid twitching. And importantly, focal seizures won't always have a loss or even a change in consciousness. Generalized or grand mal seizures are another example, which involve the entire forebrain, and these classically have full body convulsions and a full loss of consciousness. Alrighty, and then finally we get to the post-ictal period. This is the period of time following a seizure event, and in contrast to the pre-ictal and prodromal phases, almost all seizure pets will experience the post-ictal phase. Common signs include abnormal behavior, disorientation, weakness, blindness, autonomic dysfunction, and continued sensory and motor dysfunction. Importantly, from an emergency standpoint, the post-ictal period is generally when we're going to notice a lot of the physiological disturbances that occur with seizures, including hyperthermia, tachycardia, respiratory depression, and serious increases of intracranial pressure, all of which can be life threatening. So it's important to monitor your post ictal patients very closely. All right, so let's dive into what is status epilepticus. Status epilepticus is classified as a generalized seizure that lasts for more than 5 minutes. An addendum has also been added on to include greater than or equal to two generalized seizures with no return to consciousness in between them. These seizures are problematic because the longer they continue, they can become non self limiting and lead to neuronal damage and death, seriously altering neuronal networks and increasing the likelihood of future seizure events. The duration of these seizures are clinically important because, as we will discuss in a few slides, this determines how refractory the seizures are and what treatments will be the most effective. Okay, and what are cluster seizures? Cluster seizures are defined as having more than one self limiting seizure within a 24-hour period. These are also incredibly important to identify and treat because, depending on the duration and severity, these can have very similar long term implications as patients with status epilepticus. Cluster seizures can progress to full blown status epilepticus, and they still need appropriate rescue measures to get them under control and prevent their progression. All right, so let's finally start talking about treatment guidelines and the different recommendations made by the ACVIM. Starting off, we have this really nifty chart. This chart can be found in the guidelines, and it is incredibly helpful at showing how the duration of a seizure event causes specific physiological changes, which dictates the appropriate type of anti epileptic therapy that we utilize and which will be the most effective. Key takeaways from this chart: we need to be efficient and aggressive with our treatments to get cessation of seizure activity, and the times listed here are just estimates that help determine what therapies will work best. However, it is not recommended to wait a full 30 minutes before attempting other therapy options, and just because a seizure has lasted longer than 5 to 10 minutes does not mean you shouldn't attempt the first line treatments first. Always start with first line, then move to second, then move to third. The guidelines also provided a useful tool to help group anti epileptic medications based on their recommendation. As you can see, they're grouped A through E. Group A drugs are highly recommended and safe. Group D drugs are not recommended at all and are either ineffective or unsafe. And Group E is special cases that are either potentially effective and safe, but we lack clinical evidence to recommend them. For all drugs listed, I have their frequently used doses as well as their group the ACVIM has put them into based on recommendation. Okay, so let's get started on the treatments by going over our first line therapies, and we'll start with the bread and butter of seizure treatment, which are the benzodiazepines. These work by binding GABA A receptors, causing allosteric change and increasing the receptor's affinity to GABA, which increases its binding and causes inhibition of the action potential. Importantly, these will only work in the presence of GABA, and as seizure duration goes on, the GABA A receptors will become internalized and have reduced formation, making these drugs less effective. Important notes: midazolam, while it is incredibly effective, it has a relatively short half life. So, after an initial bolus, it is recommended to proceed with a CRI for continued control as needed if they're responding well to it. It can be given intranasally, intravascularly, and intramuscularly. And when there's no IV access, intranasal midazolam is the most effective rescue medication we have available, as it is the most bioavailable via this route. It generally has more reasonable volumes that you need to administer, and it can not only get adequate serum concentrations very quickly, but it can get direct penetration into the brain via the olfactory and trigeminal nerve, which is super interesting. Diazepam has a slightly lower bioavailability with increased duration to adequate serum concentrations. It shouldn't be administered intramuscularly because, unlike midazolam, it is lipid soluble and its absorption is slow and erratic via this route. And when intranasal or midazolam is not available, rectal diazepam is going to be our next best rescue therapy. Okay, so moving on to our second line therapies, we have levetiracetam and phenobarbital. Starting with levetiracetam, or Keppra, its mechanism of action is not completely understood, but what we do know is that it reduces presynaptic depolarization and calcium-induced release of neurotransmitters via binding the presynaptic 2A vesicles and by inhibiting calcium's release from the endoplasmic reticulum. Notes on Keppra is that it can be administered IV, IM, and rectally when needed for rescue situations. It is considered an effective option for pets with known hepatopathies, unlike phenobarbital. However, I did find one retrospective study on the renal impacts that did find dogs with CKD had clinically significant increases in their BUN and creatinine following administration, as well as increased likelihood of side effects. So Keppra might not be your first choice for known CKD patients. Keppra is also incredibly interesting because not only does it have known anti epileptic and epileptogenic effects, but it is also believed to be neuroprotective and reduce inflammation within the brain. Super cool. Our next second line therapy is probably the most well known and trusted long term anti epileptic drug, which is phenobarbital. Pheno works by binding to specific sites on GABA A receptors, which is different from where the benzodiazepines bind, and increases the duration of chloride channel opening, leading to hyperpolarization and reduction in the formation of action potentials. It is also inhibits AMPA receptors, which reduces the impact of excitatory glutamate. Notes on pheno is that when it's being administered IV for patients that are not already on phenobarb long term, giving one large bolus to get adequate serum concentrations is generally recommended. And where those that are already on the drug long term, you can consider just getting them started on smaller boluses every 4 to 6 hours. It is an important reminder to check hepatic function and phenobarbital levels if possible when considering administration of this drug. However, in an emergency situation, stopping the seizures takes priority. Last but not least are the third line therapies, which are used for refractory status epilepticus that hasn't responded to any of the previous treatments. What the third line therapies all have in common is that they are all anesthetic agents. Usually, the major concern for these medications is safety rather than efficacy because they will sedate your patient and stop seizure activity, but you want to ensure that they survive the process. The first drug we will discuss is ketamine, which has had multiple different studies evaluate its effectiveness alone or in combination with other drugs, and they have found great success. Ketamine works as an NMDA antagonist, which will inhibit extracellular calcium entry, reducing action potential formation. Since ketamine is also blocking NMDA receptors, it prevents downstream changes that can prevent GABA A receptor internalization and downregulation. Primary risks we're worried about include tachycardia, hypertension, and at very high doses, respiratory depression. There's also some concern for potential paradoxical effects leading to reduced seizure threshold and even triggering seizure activity when it's administered outside of the ictal period. However, this was only one of 28 patients in the study that voiced it. Our next drug is propofol, which is another drug that has been classically used and works very well. Propofol works by binding GABA A receptors at specific non benzodiazepine sites, causing an influx of chloride ions and hyperpolarization. And it also has some activity at NMDA receptors, very similar to ketamine. When administering propofol, these patients should be intubated and under constant monitoring due to risks of cardiovascular and respiratory depression and loss of their gag reflex. An important consideration is that propofol has a cumulative effect with repeated doses and CRIs. Cats are particularly sensitive to this due to their reduced metabolism, which can lead to adverse effects including Heinz body anemia. It is one of the only drugs that has had research done with notable efficacy in cats, so just because of these things, it doesn't mean you shouldn't use it, but it should be used with caution and potentially longer hospitalization stays following its administration. Next, another effective option is dexmedetomidine. Dex works as an alpha 2 agonist that reduces excitatory neurotransmitter release via suppression of norepinephrine release from the amygdala, hippocampus, and cerebral cortex. It is also considered another really good option because it reduces cerebral metabolic and oxygen demands. It causes vasoconstriction, reducing cerebral edema formation and helping maintain normal mean arterial pressures. And it is useful in recovery because it is reversible and helps reduce dysphoria caused by other medications, which can worsen the post-ictal state. Major risks with DEX include cardiovascular and respiratory depression, as well as hypothermia. Our other anesthetic options include barbiturates and inhalant anesthetics. We aren't going to dig too deep into these because these are thought of as last resort options due to the severity of their adverse effects. Both require intubation with constant monitoring and great caution to avoid overdose. Common adverse effects include severe cardiovascular and respiratory depression and death. Again, these options exist but should only be attempted with severe refractory status epilepticus, and generally, if we're getting to this point, quality of life conversations need to be made. This is just a diagram that summarizes everything that we just spoke about and can be found in the ACVIM guidelines. All right, so finally, let's dig into the treatment of cluster seizures. We'll be focusing on the short-term treatment plan for cluster seizure episodes, and particularly those that are refractory. We won't dig into long-term anti-seizure treatments. And also, there's a lot of drugs that we're going to repeat from when we were discussing status epilepticus, so I won't be repeating that information either. So, treatment for cluster seizures can be divided into 3 steps based on duration and how refractory they are to treatments. Step 1, you want to start with your fast acting medications like the benzodiazepines that we previously discussed, or you can consider longer acting medications such as levetiracetam. At home, that drug can be administered orally or rectally if possible, but otherwise, injectable routes are effective when in the hospital. Pulsatile therapies are also recommended to get effective serum and brain concentrations. Step 2, if cluster seizures continue despite your initial treatments, you can either A, administer a longer acting benzodiazepine like oral clorazepam or clorazepate via a pulsatile therapy, or B, adjust your anti-epileptic drug treatment by adding additional drugs or adjusting dosages. Step 3, if still refractory or if they've developed status epilepticus despite your polytherapy, you would follow treatment protocol for refractory status epilepticus. Okay, and that's everything. Does anyone have any questions?